All right, welcome back. I hope that we got to a lot of your questions. I'll be around afterwards in case people have more questions, and I'll be at the research table this afternoon. So I'll tell you in this session a little bit about the heart research we're doing at UT Health Houston. And these are the 3 questions that we kind of are working on right now. So one is, how can having a mosaic karyotype affect your heart health? 2, why is bicuspid aortic valve so common in Turner syndrome? And what causes a bicuspid aortic valve to form? Those are the questions that people asked us, like you, and we went and looked in the lab to find an answer. So the work that I'm presenting is a collaboration funded by the National Science Foundation between our lab and Rice University, which is across the street from us in Houston. They have a biomedical engineering program that looks at heart development. All right, so I'll be presenting work from several of our students who are learning about Turner syndrome. As part of our center, we educate medical students and residents. What is Turner syndrome? We try to get them interested in taking care of people with Turner syndrome so we can get a new generation of doctors who can know about Turner syndrome and help you all. And so some of them work on our research projects. These are some young doctors who worked on the project. So I'll start out talking about an overview of the research on bicuspid aortic valve and why it's so common in Turner syndrome. So again, this is the view that I get as a cardiologist. The valve with 3 cusps on the left, the bicuspid valve on the right. The way I tell that someone's valve is bicuspid is that it opens funny. It looks like a fish mouth. It doesn't look like a nice, smooth opening. And then we can do other tests to figure out how the valve is functioning. And of course, we then look at the aorta because, as I mentioned, a lot of people with bicuspid valve also have aneurysms. So you want to check that aorta and make sure that you're seeing the whole aorta, 1, and then 2, when you adjust it for the person's body size, is it larger than you expect? That's how you define an aneurysm. And of course, what we're trying to do is predict and prevent which people with bicuspid aortic valves and aneurysms are at risk for aortic dissection, which is the biggest risk of all. As I mentioned, we have a lot of research to do to make that better. But what we hope to do is be able to look at someone when they're a kid, tell them who is at high risk, put them on an effective medicine to prevent dissection and prevent the growth of the aneurysm. And eventually also to treat the bicuspid aortic valve so that they never need surgery. That would be the goal, right? Okay, so how common are bicuspid valves and aneurysms in someone with Turner syndrome compared to someone without Turner syndrome? So on the column that says POP is population. So in the general population, about 1 in 100 people have a bicuspid valve. Of those, 80 of those people will never know that they have the bicuspid aortic valve in their lifetime. It's something that we only pick up on autopsy because it never caused them problems. In Turner syndrome, the rate is 1 in 3. So you can see it's 30 to 50 times more common in Turner syndrome than in the general population. Thoracic aneurysms are even more common in Turner syndrome. So 1 in 500 in the population, 1 in 3 in Turner syndrome. So several hundred times more frequent. The rate of dissections, as I mentioned, it's rare compared to the frequency of bicuspid valves and aneurysms, which is reassuring, but it's still higher than the general population by 20 times. And if you look at the people who have dissections based on the research that we did in the registry and the Healthy Heart Project, the average age is 30 years, so young people, and almost everybody who had a dissection had a bicuspid aortic valve. So that's where that information I told you about risk in the previous talk comes from. We looked at all the people in this group of our Healthy Heart Project who had a dissection, and many of them had high blood pressure, bicuspid aortic valve, and coarctation. So those are the known risk factors. So why do we think that these are so much more common in Turner syndrome than in the general population? Well, if you think about Turner syndrome as a sex chromosome aneuploidy. That is, aneuploidy means an abnormal number of sex chromosomes. Then we can line it up and look at people with XX karyotypes, men with XY karyotypes, and then you have a person with Turner syndrome that has a single X chromosome. So the only thing that's different between the Turner syndrome group and the first two groups is that the number of sex chromosomes is less than 2. Keep that in mind. So in an XX person, there's no Y gene present. So you have 2 X chromosomes to make 2. In a male with an X and a Y chromosome, you have 2 sex chromosomes still. X plus Y equals 2. But in women with Turner syndrome, there's only 1 sex chromosome. And so we think that that leads to a lower number of copies of genes on the sex chromosomes is what directly leads to the increased risk for bicuspid aortic valve and thoracic aortic aneurysms. And we can show that with genetic testing. So this is some work that came out of the NIH study that many of you have participated in, where we took genetic material and in people who had been tested for bicuspid valve or not, and we looked at how many of them had 45X karyotypes, other karyotypes like deletions that are a little rarer, and isochromosomes, which are also a little bit more common, but still much less frequent than 45X. And what we found was that the rate of bicuspid valve is basically proportional to the number of sex chromosomes that you have. So with someone that only has 1 sex chromosome, a 45X karyotype, half of them had a bicuspid valve. When we looked at someone who had 2 X chromosomes, but a deletion on one of them, so like 1.5 X chromosomes, the rate was 25%. So half the rate of the person that only had 1 X chromosome. And when we looked at isochromosomes, we didn't find anyone who had a bicuspid valve and had only an isochromosome. So that was in a group of 400 people that we looked at at the NIH study. And so the amount of sex chromosomes that you have is directly proportional to your risk of developing heart abnormalities that you're born with. And then we also did some tests to find out, well, are there other genes that kind of predict whether you have a bicuspid valve or aneurysm? And we found some. We found some on other chromosomes, not the X or Y chromosome. And when we add those up, having one of those genes and having a bicuspid and having a 45X karyotype, it kind of adds together. So this graph is showing what the rate of BAV was in someone who had a gene, who did not have a gene and did not have a 45X karyotype. So it was 20%. And then if you look at the right side, these are people who had a 45X karyotype and had the gene present. Their rate was 3 times higher. So 60% of those people had a bicuspid valve. It looks like there's a straightforward genetic risk related to the number of genetic markers you have and the likelihood that you're born with BAV. And this is very clear in Turner syndrome. It's not so clear in other conditions. So as I mentioned, the most important thing to know if you have a bicuspid valve or Turner syndrome, and Turner syndrome is that you need lifelong care. Follow up with cardiologists, know how frequent your imaging needs to be, and in many cases, if you have high blood pressure, you should take blood pressure medication to lower your risk of a dissection. So in this case, I'm also providing another pitch to reach out to a Turner syndrome specialty clinic and participate in research, because we want everyone to have that opportunity as we learn more about these conditions. And there are many unanswered questions that I'll go into now. This is our group at UT Health Houston. We have an ongoing study where we're taking blood from people with Turner syndrome who are mosaic. And I'll talk about that study. But you can contact us if you're interested. All right. So that was my section in kind of introduction. Now I'm going to talk about the work we're doing with the Rice team to look at how bicuspid aortic valve forms and what might go wrong in Turner syndrome. So this is work from Jane Granda Allen. She's a bioengineer at Rice who has developed a way to grow aortic valve tissue in culture and look at how it forms. And one of the things that we look at is how aortic valve composition or structure is different in people with Turner syndrome, how that causes a bicuspid aortic valve, and why that makes the valve wear out. So heart valves are actually amazing structures, right? They have to open and close millions and millions of times during your lifetime. They have to be springy, but also tough to withstand the forces of that opening and closing, and they have special structures to do that. The special structures are kind of woven together fibers. And so their lab studies the relationship between how heart valves form and their properties, how well they open and close, and whether they get stiff or not. And we can actually culture valve cells and simulate how the heart valves form in a dish, and then look at how changing the heart cells, like in having a Turner syndrome karyotype versus a normal karyotype, affects those cells and the valve function. So we're studying both the types of cells that we use in this system, so whether they're Turner syndrome cells or cells without Turner syndrome, and also what the kind of blood flow that happens in heart valves. How does that affect the way the cells behave? And these are the forces that we look at. So stress, this is pressure that are put on the cells, like if you're pressing down with your palm, and strain. This is pressure that causes the cells to stretch. Both of those happen when heart valves open and close. And so depending on how the valves form and how the cells are responding to flow, you can get different levels of stiffness, and the valves open and close differently. And these are the ways we stress the cells in culture. We can either pull on them, so pull on them horizontally. We can press on them, so compression. And we can also shoot fluid over them. That's called shear stress. That's the way, you can think of it like in a blood vessel, the way blood flow shoots over the cells and causes them to change. So the cells respond to all these forces, and we can actually measure how they change by taking pictures of them. We can also look at how their DNA and how their genes change in response to those forces. So why does this matter for Turner syndrome? Because we think that having abnormal cells to start with means that they don't respond to blood flow in the same way as normal cells. And over time, this leads to things like valves wearing out faster or aneurysms forming, where they wouldn't happen in people without Turner syndrome. So we're studying the interaction between your genes and how the environment of your heart functions. So one of the ways we do this is using stem cells. You might have heard of stem cells. They're cells that we can take from your body and kind of reprogram to form any other type of cell. So we could take a skin cell and turn it into a blood cell. We can take a blood cell and turn it into a heart cell. It's an amazing technology, and it allows us to take cells from people and look at cells that we would never be able to study in a normal situation, because we're not going to take heart cells from people who don't need heart surgery, right? So this way we can take cells from a lot of different people and look at how they are different. The cells that we're focused on are from the middle layer of the embryo that forms the heart, because we think that heart abnormalities being so common in Turner syndrome, probably those cells are not normal, and we want to know why they're not normal. So we can turn these cells into endothelial cells. Those are the cells that line your blood vessels in your body and also the valves in your heart. And they control how the valves form and function. So our hypothesis was that something about these endothelial cells in Turner syndrome is abnormal, and it's causing bicuspid aortic valve and aneurysms to form. So in this case, normally endothelial cells are really important. You can't live without them. They prevent your blood from clotting inside your arteries. They regulate the kind of immune response that you might need. They can prevent atherosclerosis, right? We said atherosclerosis is super common in Turner syndrome, so that is an endothelial problem. and they're needed for heart valve formation. We also know that they respond to blood flow, so we wanted to see if they are behaving normally in people with Turner syndrome. So the idea would be that if you have abnormal endothelial cells in Turner syndrome, it's not regulating the way the heart valves form, and you get a bicuspid valve. And this would be more common in someone with a 45X karyotype. So how do we make stem cells from people with Turner syndrome? We draw your blood, and we try to do this from people who are mosaic. So typically someone with Turner syndrome who's mosaic would have one cell line with 2 X chromosomes and one with less than two sex chromosomes, right? So we were able to get blood cells that have both types of cells from the person with Turner syndrome. And if we turn those blood cells into stem cells, we then have 2 sets of cells from one person that we can separate out and study and compare one cell type to the other cell type. That's like your own best control, right? It's both from you, and it's identical in every way to your other body cells, except for just having 1 or 2 X chromosomes. So we take the blood cells, we turn them into stem cells. These stem cells now have Turner syndrome karyotypes. And then we turn those stem cells into endothelial cells. And then we test them to see how they respond to flow in the lab. And so these are different karyotypes that we have made lines from. So thanks to volunteers like you coming to our clinic in Houston, getting their blood drawn, we turn them into stem cells that look like this. And then we turn them into endothelial cells that look like this. So when we did that, we noticed a few things. The first thing that we noticed is that the cells that are 45X are smaller than the cells that are 46XX. And that's pretty understandable when you think that people with 45X karyotypes are smaller than people with 46XX karyotypes. But it's kind of cool to see it even at the cells. Even the cells are smaller, individual cells. They also grow more slowly than 46XX cells. So, using this system, we want to understand why BAV is so common and actually understand what genes cause that difference. Because if we know the genes that cause it, we can develop new medications to prevent future problems like heart attacks, strokes, and high blood pressure in Turner syndrome. And in fact, we think that this can be used to study all kinds of sex chromosome differences that determine heart and blood vessel problems. So this is some work that we're doing to study which genes might be responsible. So as I mentioned, on the left here, we have a normal cell with 2 sex chromosomes on top and a Turner syndrome cell with 45X on bottom. We're going to take the RNA, which is basically genes that are, and proteins that are produced in the cells, and compare them. Remember that these are from the same person, so the only difference is the number of X chromosomes. And we're going to measure the levels of genes in both cell types, finding out which ones are different. If we can know which ones are different, that will tell us something about why the cells behave differently. So the ones we looked at first were ones on the X and Y chromosomes. We also looked at genes on the short arm of the X chromosome because Carolyn Bondi and her group at the NIH had shown that these genes are probably related to bicuspid aortic valve. And then we looked at genes that had very different levels in 45X and 46XX cells. So these are some genes that we looked at so far that are very different in Turner syndrome. So the 2 genes on top are on the X chromosome, and we think that they play a role in heart and blood vessel development in Turner syndrome. And interesting thing is the top gene actually controls many genes throughout the other chromosomes. So when we look at those genes, they're all different too. But it's kind of like the X chromosome is the master chromosome. It kind of controls all these genes. And when you have less of it, those genes don't behave properly. And we can tell that when looking at genes in general in the cells. And we found several other genes that are responsible for the way cells move when they're forming heart valves. They're not normal in Turner syndrome. So we think that not only are the cells abnormal to begin with, but during heart development, they don't move into position properly, and they don't respond to blood flow properly. And that these specific genes can be part of a program that we could help to reset to fix those problems. So this is the beginning of a new potential treatment for Turner syndrome. And so where do we go from here? Right now, we're looking at how, when we turn these stem cells into endothelial cells, what goes wrong in Turner syndrome to make those differences happen. So we're measuring at different steps how the genes turn on and off and what is different in Turner syndrome. And then we've identified all these genes that don't behave properly when we turn them into blood vessel cells. So the next step is, can we reverse that and figure out how we can make the Turner syndrome cell more like the normal cell? And then we can test their behavior in response to valve development and flow. So one of the ways we test flow is we put them in this contraption that's called a cone and plate system, and it simulates the force of blood flowing over the cells during heart development when the heart is beating. So we can put our cells in this system and study how they respond to flow. And we think that the way the cells respond in Turner syndrome is different than in people without Turner syndrome. So we started out by doing this in pig hearts because pigs actually have a heart that's closest in size and function to human hearts. And we wanted to see if we can get the system to work. So we would scrape the valve cells off of pig hearts and put them into this dish and expose them to flow. And after we got that working, we then took our cells from Turner syndrome patients that I showed you with different karyotypes, and we put them in this dish. So this is how we did it. We took the blood cells, we turned them into stem cells, and we took the stem cells and turned them into endothelial cells, and then we put them into this dish and exposed them to blood flow at different levels, the same as we did for the pig cells. So the idea was, if we compared cells from the same person, one with one X chromosome and one with two X chromosomes, would they respond to flow in the same way or different ways? So this is how we did it. So the arrow shows which direction the flow was going on the cells in the dish. And what we found was that normally cells line up in the direction of flow, right? They line up north to south, just the way that arrow is going. And you can kind of see that in the fluorescent picture on the bottom right. The cells all look like they're kind of going in the same direction. We actually can get a computer to do the work for us and just show us how the cells are lining up, but it's pretty reliable. What we found was that that didn't happen with the Turner syndrome cells. They didn't line up the way they were supposed to. And so that shows that their ability to respond to flow, which is a fundamental property of endothelial cells, is different. And we think that some of the genes that we found can explain that. If we can get the cells to behave by changing that, that would be the first sign that our treatment might be working. And one of the other things that we're doing to test this is not only putting them in a dish, but we've developed a gel that allows them it makes it seem to the cells like they're in a beating heart because it simulates heart tissue, and that makes us better able to model this kind of process. So we use hydrogels, which are spongy materials that look like heart valve tissue. We embed the cells in them, and then we expose them to flow. And that is more faithful to what the cells actually experience as in the developing heart when the bicuspid valve is forming. And this is kind of what it looks like. We can actually change these to become stiffer or thinner depending on whether we want to make it seem like a bicuspid valve that is calcified or a regular valve, and then we can see how the cells behave in those different environments. So the goal here is to understand how changes in flow and heart composition affect the behavior of the cells, and how the changes in the cells will be different in people with Turner syndrome because these cells don't respond in flow to the same way. Now, putting it all together, we're modeling heart development in Turner syndrome. We've found out a way to grow XX and X cells from people with Turner syndrome. We found out a way to turn those cells into heart and blood vessel cells. and then exposing them to growth conditions that occur in the embryo when heart valves are forming. We can simulate blood flow and then measure the changes in the genes that are different in people with Turner syndrome to identify potential causes of these changes. So the idea is to identify genes that turn on or off abnormally in heart and blood vessel cells in Turner syndrome, to develop new treatments that can prevent problems related to abnormal blood vessel function in Turner syndrome, and more fundamentally, to understand differences between males and females as it relates to heart and blood vessel problems. So I think that's it for our research update on heart and blood vessels. Any questions? I hope that was interesting. It's interesting to us because we work on it every day, but it's a little hard to explain. So if I wasn't clear, please let me know. Is it less likely to have a BAV in mosaic TS than the classic TS? Yes. So we know that the ratio, the more XX cells you have as a mosaic, the less likely you are to have a BAV. There isn't a lower limit that we found where you cannot have a BAV. It's possible. It's just overall less likely. If you look at a population of people who are mosaic, the rate of BAV is much lower. Is there a correlation between Turner syndrome and arrhythmia? As several people have mentioned, having a fast heart rate is super common in Turner syndrome, and it's not necessarily the same risk as having an arrhythmia. There are certain situations where an arrhythmia like atrial fibrillation, which is the most common one, can happen in Turner syndrome. That's generally related to obesity, sleep apnea, and high blood pressure. So if you have those three things, you're more likely to have an abnormal rhythm. And the treatment, the most effective treatment, is actually to treat those underlying causes of the arrhythmia. And that usually resolves it. Sometimes you have to have a special heart treatment to prevent the arrhythmia from coming back. Let's see. How does age affect your study samples? So that's a great question. So in most cases, we prefer to have samples from younger people with Turner syndrome. And the reason why is that it's easier to make stem cells from younger people. Why is that? It's true for everyone, not just Turner syndrome, that your cells become less resilient as you get older. And so it's harder to make stem cells. And for that reason alone, we prefer younger donors. That's not to say that there isn't value at looking at the older cell group, but we had restrictions on the number of volunteers we could use. So for sure, in future, we want to compare young cells to older cells in Turner syndrome, because if anything, the differences should be more pronounced. Doesn't CBC measure blood cell size? If so, does that truly affect anything? So complete blood count, that's the test you get from your doctor. And I think they're talking about the red cell size that's usually reported. And it's a common test. There's no indication that there's anything majorly wrong with that value in people with Turner syndrome as a rule. And if you have an abnormality in your CBC, there's usually a way to do follow-up testing to figure out what's causing it. A frequent example would be if you are anemic, your blood count will be very abnormal, and your doctor can do a test to figure out why you're anemic and how to treat it. Okay. What is the common age for BAV replacement in TS girls? There is no common age. It really depends on the function of the valve, and so that's a question to ask your doctor. Not everyone with a bicuspid valve needs to have their valve replaced. It's not inevitable. There are good ways to take care of your heart valve to make it last longer. One of them is, of course, to control high blood pressure, because that decreases the wear and tear on the valve. But there are other things that you can do, and really everybody's an individual who has a different timeline for their valve. You need to get accurate information about it. Are there plans to use AI for this type of research? We actually are using AI to help us figure out the best way to monitor the cells. We have thousands of cells, and we want the computer to be able to track them so that we can understand how they're behaving. And AI is useful for that because the computer can learn how to do it better on its own. Please discuss weight training as it relates to TS ladies that have had heart surgery. Yes, so usually I do give a talk on exercise. That's one of our interests. And in Turner syndrome, it's very important to maintain exercise for bone health because a lot of people develop low bone density as you get older. And exercise has been shown to be one of the best ways to prevent that. If you have had aortic surgery, people might tell you not to exercise, but we now know that that is a bad advice. Not only is it bad for your bones, it turns out that it's also bad for your heart and blood vessels. Your heart and blood vessels will get weaker without exercise, and if anything, that makes the risk higher. So our current recommendations are to continue exercise after dissection, and that even resistance exercise can be done safely after in somebody who's had a dissection. We have an ongoing clinical trial looking at this in our patients. We've tested hundreds of patients, and we haven't had anyone have problems with the kind of exercises that we're talking about. So that's low to moderate level, aerobic and isometric exercises where you're contracting muscles. It is actually very important to maintain your muscle mass and bone health as you get older. Would this research lead to replacing surgical coarct repairs? So potentially, if you could figure out how the blood vessels are, why they behave abnormally in Turner syndrome, you could prevent things like high blood pressure, aortic aneurysms getting bigger, or even coarcts reforming after surgery. But we don't know that yet. That would be the goal of this kind of treatment. Are there age limits for your research? No, there are no age limits currently. Like I said, we have been preferentially making the stem cells from younger people, but we intend to keep doing that and expanding our scope to get samples from older people too. We think it's important to represent everybody with different types of Turner syndrome. Have you studied the TSL's reaction with Dacron to repair aortic dissection? Great question. No, we have not. One thing that we do know in Turner syndrome is that you can form aneurysms in places that you've had aortic repair after the repair, after recovering from surgery, even decades later. An example of this would be one of my patients who was 75 and had a coarct repair at age 25, developed an aneurysm in her descending aorta, so in the chest, below where her previous repair was, 50 years afterwards. So again, it's a lifelong disease, and we know that the areas around the repair sites where Dacron has been used do tend to develop aneurysms and need to be monitored. But we don't understand the risk factors for that. So that's another great example of a research question. Has the success rate of preventative repair been studied long-term? We don't have a lot of long-term data. Our group is looking at this in people who have had aortic surgeries, and we can say that up to 20 years, the outcome appears to be excellent. There haven't been any long-term deaths. Nobody's had to go back and have their repair redone. And I think there have only been 1 or 2 additional aortic problems that occurred in that group, which is it's 54 patients so far who have had aortic repairs in our study. We're hoping to publish this result this year or early next year, and hopefully we can update you at the meeting next year about that. But the long-term outcomes are good. My daughter had coarctation when she was a baby, and she had surgery. She has PAPVR, that's the abnormal veins, but is okay. She has lymphedema. She has infections because of lymphedema and 1 kidney. Can the coarctation come back? Can the PAPVR give problems? Can the lymphedema is related to these problems? So the answer is the coarctation can come back. It's unlikely, but we do recommend monitoring lifelong after coarctation repair because sometimes even in adults, as I mentioned, decades after the repair, you can have problems. And they're not often visualized by echocardiograms. So if someone's having an echo and they're thinking they're doing good follow-up, if you have a history of coarctation, we do recommend at least once every 5 to 10 years, if nothing is changing, to get a CT or MRI scan of that coarctation site, because we do think that it can change over time. We do have someone in our clinic in Houston who specializes in lymphedema research and also lymphedema treatment. We have a lymphedema clinic. So anyone who requires lymphedema problems, we have a website. You can list that as one of your problems that you would like us to deal with, and we can get you an appointment with the lymphedema clinic while you're in Houston. What is considered high blood pressure in a 9-year-old? Great question. There are specific guidelines for high blood pressure, and it's based on a different set of criteria for kids than adults. We don't use the 130/80 for kids, and your pediatrician will know how to assess your kid's blood pressure. It's based on a scale, a kind of a nomogram, similar to the way they assess the aorta, but it's specifically for blood pressure. So you should know the percentage that you are, and if it exceeds the 95th percentile for your age, then it's considered to be high in kids. For women with high blood pressure, how often should you test, and when is the best time? If you have a history of high blood pressure, you should always check your blood pressure at home for the reasons we talked about. People tend to get nervous in clinic, and so your blood pressure when you go to the doctor is not your blood pressure. It's just a response to being at your doctor's office. So keep a home blood pressure diary. We recommend doing 24-hour blood pressures at least once a year when you go to clinic to make sure your blood pressure is controlled. And the best time to do it, it's really different times of the day if you're checking it at home. You want to do it, if you do it only at one time of the day, you might miss a time when your blood pressure is high. And you don't need to do it every day. What I tell people is to every couple weeks to do it for a period of 2 to 3 days, but a lot of times a day, like 5 to 6 times a day. That's far more effective than doing it at 7 a.m. every day for a month. And the reason is that you can see these additional blood pressure times and sometimes pick up fluctuations in the blood pressure. Is the echo the best way to check a toddler's blood pressure? Usually not. There are different ways to check a blood pressure. Sometimes it's difficult to get an accurate reading in toddlers. I'm not a kid doctor, so I don't have to deal with that. But the best way is to ask your pediatrician if you're concerned. And what we do recommend in kids is blood pressure in all 4 limbs, arms and legs, for the reason that you can pick up a coarctation that way. As I mentioned, in coarctation, your blood pressure would be much lower than expected in your legs. Do cholesterol medications cause high liver enzymes? Yes, they can, but in most cases it's not serious. It's something that you get picked up on a blood test. If it comes above a certain level, there are so many cholesterol medications that your doctor can often switch you to one that's safe for you. Most of the time that's not necessary, it's just something that shows up, so don't be alarmed about it, but do ask your doctor if your liver enzymes are abnormal, if something needs to be done about it. Do you need to sign up for both the Healthy Heart Project and TS Registry? So we're not doing the Healthy Heart Project this year, so you can't sign up for it, but there is a Healthy Heart table, and that is for people who did the Healthy Heart Project before at any of the meetings to transfer their data to the registry. The reason why this is important is because the Oregon group is retiring the Healthy Heart Project as an independent study this year. It's going away, and if we don't get your permission to transfer your data, it will be lost. It won't go into the registry. So we do want to preserve that data for future researchers to look at. It is very valuable. It's the largest set of data that we have on echocardiograms over time in Turner syndrome. So please, if you did participate, go to the table and sign the form. It takes 2 minutes. The registry is something we encourage everybody to sign up for, and it also takes only a few minutes. We have a QR code at the table that you scan. How common is low blood pressure? Pretty common. It's related to this autonomic problem that we talked about, the same thing that causes high heart rates, and it doesn't seem to affect our other medical treatments. The main issue that we get into is that sometimes people can't take all the blood pressure medicine that we want them to if they have another heart or blood vessel problem. But in most cases, it's not a severe problem, and people can manage low blood pressure. The treatments for low blood pressure are worse than having low blood pressure, so I don't usually recommend them. If you have to be on a medication for low blood pressure, you should really question that with your doctor, because in most cases, we find that people don't need that. It can cause more damage to your heart and blood vessels than the low blood pressure itself. Does the beta blocker help reduce the chance that calcium builds up? It will not necessarily do that unless it lowers your blood pressure. Lowering your blood pressure will reduce calcium buildup and improve valve function. The other things that will do that are treatment of your blood sugar and any kidney problems. So those are the things that we look at in somebody with a bicuspid valve if we want to make sure their valve lasts a long time. How would you change the cells? Is it like doing cell therapy? So the question was, if we had a treatment, how would it work for Turner syndrome? The answer is what we really want is a drug that everybody could take that would prevent their aneurysm from growing, prevent them from developing high blood pressure, or having an aortic dissection, right? That would be the goal. No gene editing at all. We think we can get there with some of these cell studies, but we could also imagine a situation where we could edit the genes in the cells and actually turn them on or off. And that's something we can also do in the dish, and it's something we're proposing to do. We don't know which one will be more effective yet. Is it safe to take calcium supplements after valve replacement? That is a really good question. There is some data, not from people with Turner syndrome, but it's something that we should be looking at in Turner syndrome, that taking calcium supplements can increase calcification of the heart and blood vessels. And obviously, we would want to avoid this if you had a bicuspid valve and you thought that calcium buildup might be bad for your heart. So the answer is we don't know in Turner syndrome, but I do caution some people from taking very high amounts of calcium if they've already had calcium in their heart and blood vessels. And that is an individual decision. We don't have any great advice for you yet. It's something that we should work on. Are elevated liver enzyme levels associated with Turner syndrome? Yes, they are. They're very common, and most of them have to do with what we call fatty liver. So the endocrinology doctors may talk to you about that at some point. Fatty liver is based on, among other things, elevated liver enzymes and some abnormal liver ultrasound tests. It's very common in Turner syndrome. We don't understand if it causes long-term health outcomes at this point. It is, in most cases, it's something that we see. We kind of recommend you change your diet. You maybe lose weight at some point, but we don't have a firm idea about how serious the problem can become in most people. So that's another area of research. Is any research or thoughts on GLP-1 receptor agonists? So these are things like Mounjaro, things like Ozempic that people have heard about. They're very common and actually becoming hard to get because they're being used by everybody, whether they're obese or not. These can be very effective for weight loss. Do we have any data on them in Turner syndrome? No, we don't have any data in Turner syndrome. So one of the things that we'll be looking at in future surveys is how many of you are taking these medications and if you've had any side effects, because we think that's important to get out to the community. And so please contribute to research in that way. If a teenager had a normal heart but developed a vertical premature complex, is that a forewarning of a future problem? I think ventricular premature complex is probably what you meant. That's an electrocardiogram abnormality. And it can mean that the heart is irritated or having some other issues. So whenever we see that, or if they're frequent, we do additional testing to find out if there's a heart problem that can be treated. It is not normal, and it is a concern. The amount of concern really depends on other factors. But you should definitely talk to your doctor about that if you have one of these PVCs or premature ventricular contractions. Can you develop an aneurysm as an adult even though you were not born with one? Yes. So everyone, we think, with Turner syndrome who has an aneurysm started out without an aneurysm. So all of the aneurysms develop usually over time and usually in adults. That's the normal situation. The aneurysm can grow over time, and we can often monitor its growth. It will grow in everyone to a certain degree, but if it grows faster than we expect or very rapidly, that's when we become concerned that we need to do an operation to prevent a dissection. So yes, aneurysms develop over time in adulthood in most cases, and they all increase in size to some extent. Would I be able to send scans to you guys in Houston? Yes, you can send them. I'm happy to do a consult with you, but understand that if I don't see you and examine you, the information that you get will not be as thorough or precise as what you would get from your own doctor. But sometimes I'm willing to help or talk to your doctors if they're not familiar with Turner syndrome. What can we do if the blood pressure meds do not seem to be working? There are many options for blood pressure medications, and the usual advice is to try a different medication that works for you. Everyone is slightly different, but currently, for example, there are more than 5 different types of beta blockers and more than 10 different blood pressure medications that we can use. Most people can find one that works, but it might take a little while. For women with high blood pressure, is there a reason that medications would not effectively lower blood pressure? A similar question. The answer could be that you haven't tried the right medication for you, or the answer could be that something is causing your blood pressure to be high. In Turner syndrome, that could be things like having a thyroid disease, having untreated sleep apnea, gaining weight, having diabetes, having kidney problems. So there are lots of reasons that you could develop blood pressure that's harder to treat. And if that's the case, the first thing we do is look for any of those reasons and treat them before we focus on the blood pressure, because it usually means that your body is under stress from something else, and we need to find out what that something else is before we can treat the blood pressure. So that's a reason why blood pressure meds won't be helping. Do I have to physically come to the clinic, or can I have my info sent over? I assume this is for a question about your care. I'm always willing to look at your heart history and provide advice, again with the caution that it's not the same as seeing a doctor and getting a physical exam and getting a complete workup. But if you have a question, we're always available as a resource for the community, and I would be honored to help if I could. Can a left aorta dissection repair create the need for recoarctation? I think what that might be is, can you have problems with the coarctation if you've also had a dissection? Not typically. So typically it works the other way around. Dissections can happen at the sites of coarctations. Frequently, decades after the repair. This is the reason why I mentioned that you have to monitor those sites with an MRI or CT scan, because they can develop aneurysms, and they will not cause symptoms until the aneurysm gets large enough and can potentially dissect. So there is a relationship between coarctation and dissection, but it's probably a little different. Are low blood platelets common in Turner syndrome? Overall, low platelets are not very common in Turner syndrome. There's not any special reason why they are low. So typically, if you have low platelets, it's for another reason. And you need to get a thorough workup to figure out why they're low. But in terms of Turner syndrome itself, it's not very common. Any tips for a heart-healthy diet? That's a very common question. There is no difference between the diet we recommend for people with Turner syndrome and heart problems and people who do not have Turner syndrome and heart problems. The basic dietary information is low salt, because salt increases your blood pressure, and a balanced diet rich in antioxidants, because that slows the blood vessel inflammation and calcium buildup. So those two things are probably the most important one. And really, the rest of it has to do with how long you can stick with the diet, because the diet in Turner syndrome has to be lifelong. It can't be one that you start and stop 2 months later for the reasons that we talked about. Your blood and heart disease is also lifelong. So your dietary changes have to be lifelong. And that means finding a diet you can live with, basically, which is the biggest challenge for most people. All right. Can a coarctation repair itself? I had one when I was born, but didn't have surgery. Yes. So sometimes we see what your doctor might call a pseudo-coarct, which is just a pinched-in area of the aorta with normal blood flow. That's very common also in Turner syndrome, and that's usually the result of a blood vessel that repaired itself. So you were born with a kinked area, but it didn't ever become serious enough to block blood flow, and it gradually widened as you got older. Those, as far as we can tell, are very safe, and they don't tend to cause problems later in life, but again, we don't have a lot of data about those. Is there a recommended age for cardiac MRI? I think I mentioned that one, but it's early on. As early as we can get an MRI without sedation. And I think that we are running out of questions. Did we run out of questions?
We've been pulling from this morning session, so
they're still going? Okay. Are you guys getting tired of it? Or you want me to keep going? Okay. All right. Are there any concerns if you have a one-off high blood pressure, but it's usually you don't? Okay, so we talked about that, especially if it's in clinic. Having high blood pressure in clinic can be perfectly normal under the circumstances, and so you should definitely follow that up by checking it at home. And the most important advice would be don't overreact to one high blood pressure reading. Make sure that you know whether it's continually high when you go home or not. Do you have a need for non-TS patients with similar heart conditions to participate in your research? So for this particular study that I talked about, it's only for people with Turner syndrome because we're taking their 2X cells and comparing it to cells with fewer than 2X chromosomes for the study. For other studies, we are looking at people with bicuspid aortic valve who do not have Turner syndrome, and so we're always interested in those patients. I see them in clinic. If you have a BAV, I'm happy to talk to you about that as well. Let's see, what are signs and symptoms to watch out for in children with BAV? Again, it would be pounding in the chest, palpitations, shortness of breath, not being able to do things, keeping up with other kids. That would be a sign that there's a heart or blood vessel problem that needs to be looked at more urgently. Otherwise, of course, everyone who has Turner syndrome as a kid should see a doctor regularly and a cardiologist at least a few times before they turn 15 years old, usually at least every 3 to 5 years. Okay. I think we talked about the blood pressure one already. Oh, should you take statins even if your cholesterol isn't super high? So for many people, the answer might be yes. If you have diabetes, you might need to take a statin. Your doctor might advise that even if your cholesterol isn't super high, because we know that diabetes is a risk factor for atherosclerosis, so heart attacks and strokes. And we know that statins, the main cholesterol medication, can prevent heart attacks and strokes. So your doctor might say, even with normal cholesterol levels, your statin may still protect you. I want you to take the statin. For other people, it may not be as clear, and if you're concerned about that, you should definitely talk to your doctor about whether you should take a cholesterol medicine or not. Related to that, are there any concerns with having low total cholesterol? Can your cholesterol be too low? Well, many of us wish we had lower cholesterol, but if you can actually get it that low, there doesn't seem to be a huge risk. In fact, recently they checked people with super low cholesterol and they had the lowest risk of heart attacks and strokes. So the answer is as low as you can go. Many of us now recommend going, if you've had a heart attack or stroke, we want your cholesterol, your LDL, the bad one, to be less than 70, which is really low, right? So we can routinely get to that level with the new medications. They're very strong. Not everybody can take them, but if you can get on it, your cholesterol will be in the 50s. And that seems really low, but it seems also to work really well. All right. So have they found higher rates of diastolic blood pressure being high in TS women? Yes. So that tends to happen in young people and in people who are overweight. And we think that it actually goes down by itself as you get older. So as you get into your 40s, your diastolic blood pressure normally drops until when you're in your 50s and 60s, it's mostly just high systolic and low or normal diastolic blood pressure. So the pattern reverses itself, but in young people, actually the most common form of high blood pressure is high diastolic blood pressure, the low number, being in the 90 or 100 range. And that's something we see a lot on ambulatory blood pressure, where we wouldn't necessarily notice it in clinic. So if your diastolic blood pressure is high, but your systolic is normal, it's still high blood pressure and you still need to be treated. Don't forget that, because you can think about your diastolic blood pressure as your heart's rest period. If it's too high, your heart isn't getting to rest, and you can develop heart failure from that. All right. I've heard that TS women typically have high resting heart rates. Is this true, and why? Yes, we talked about it, so it's very common. You're not alone if you have a high resting heart rate. It's due to autonomic dysfunction, so nervous system problem. It's not a heart problem per se, as far as we can tell, because even people without any known heart problems have a high resting heart rate. And by itself, it doesn't mean anything bad is going to happen to you. But some people get unnecessary anxiety because they show up at a doctor's office, they have an electrocardiogram, and somebody says their heart rate is too high, we need to do all these tests. If I see that in someone, especially young with Turner syndrome, I reassure them, because I say, you're not alone, many other people have this problem, and it's not known to cause any issues. If anything else comes up, we'll check it, but on its own, it doesn't need to be treated. The medicines to treat it cause side effects, which are worse than just having the high heart rate. All right. How can I convince my cardiologist that's not familiar with TS to order a baseline MRI or CT? You can show them the new 2024 guidelines. We're going to have a patient passport. It's being worked on right now. It hasn't come out yet. But the idea is, to, like with the old guidelines, to have a patient version that you can carry to clinic. And if your doctor says, I don't believe in this, show them the evidence, right? That's the best way to advocate for yourself. And we're going to try to make it very understandable, easy to follow, one-page type of thing so that everyone knows what to do for their heart and blood vessels. Does Turner's have an impact on heart rate while exercising? Yes, it will be high to begin with. It may not go up quite in the same way as a person without Turner syndrome. The key is your exercise capacity and endurance the same as what we would expect? If it's not affecting either of those things, then it's nothing to worry about. All right. Is having a TEE, that's a transesophageal echo, the one that goes down your throat, sufficient, or is an MRI or CT recommended? So if you're talking about a bicuspid valve or an aneurysm, an MRI or CT is highly recommended above a TEE because it can see more parts of your heart. So a TEE, a transesophageal echo, is a special test that's usually only ordered when we're looking for very specific types of things, and it's not a good screening test for Turner syndrome. Okay. What are your thoughts on being on metoprolol and lisinopril after valve and aortic replacement? So lisinopril is a blood pressure medicine. Metoprolol is one of the medicines we use for people with aneurysms because it has been shown in other diseases to prevent dissections. And it's not unusual for people to be on those for life. There's nothing wrong with that as long as your blood pressure is under control using the information that we have and you're not developing side effects. The side effects from blood pressure medicines are typically lightheadedness, dizziness, feeling like you're going to pass out, or some abnormal blood tests. And if you're not experiencing any of those side effects, it's usually safe to remain on the medications even after surgery. It seems like for stress tests, they're using PET scans. Is that all right? PET scan is a special kind of CT scan that looks at the coronary arteries and can tell you if you have a heart artery blockage. It's one of the screening tests that I recommend for people in their 40s and 50s with Turner syndrome because it can pick up blockages that are very small and haven't caused a heart attack or stroke yet. So it is a reasonable screening test. It is being used more often. It is a little more expensive, and it's not always covered by insurance. So check with your insurance first to make sure that you get coverage because it is expensive. I would say a regular stress test is probably just as good for most people. How common is atherosclerosis, and what are the statistics as far as genetics and diet? So atherosclerosis is almost universal in Turner syndrome. So everyone gets some degree of it, and the rate at which it forms, beginning in your 40s, depends on things like diet, lifestyle, exercise, whether you have diabetes or not, whether you have high blood pressure or not. So all of those things will make it highly variable depending on the individual, but there are things you can control to prevent the rate and severity of atherosclerosis. Let's see. Please touch on left versus right bundle branch. That is very specific, okay? So those are kinds of ECG or electrocardiogram abnormalities that can occur in Turner syndrome. Of the two, right bundle branch block is more common in Turner syndrome, and it's associated with some of the things that we talked about. So if we see this on an electrocardiogram or ECG, we recommend doing other heart and blood vessel tests. An example would be abnormal pulmonary veins. So PAPVR is associated with right bundle branch block. So if we see that in a young person, we will order a cardiac MRI, right? So there are certain things that we know about in Turner syndrome that are associated with these. It's just a screening test, so it doesn't tell us for sure, and we have to follow it up with additional testing. That's the value of doing the ECG. So do we have to get a referral to get an appointment? Usually that depends on your insurance. Unfortunately, there's not much that your doctors can do. It depends on what kind of insurance you have. The old HMOs used to require referrals from your regular doctor for any specialty visits. Sometimes what we do is we make the endocrinology doctor in our Turner syndrome clinic your primary care provider, and that makes it easier for you to see other people in the clinic who are affiliated with the clinic. Please discuss weight training, I think that's what it means. Weight training as it relates to TS ladies who have had heart surgery. So that's a great question. As I mentioned, people who have had heart surgery lose a lot of muscle mass and bone density, and so we do recommend exercise as a way to recover from any sort of heart surgery. The rate and speed at which you do the exercise really depends on what kind of surgery you have and your overall physical condition. So generally starting very low impact and gradually building up, and you should do it in a supervised setting. Typically after surgery, we recommend cardiac rehabilitation or a physical training of some sort, supervising your exercise. It makes it much safer. They can monitor your progress and gradually build up. But weight training overall can be safe in that environment. We have done it for several years, and we haven't had anyone after dissection surgery have a problem with weight training if it's done properly. But I would stress that it's important to get advice about that before you proceed to start weight training, especially if it's something you haven't done before. Any thoughts about severe edema in the feet? So in Turner syndrome edema, we think about lymphedema, but there are other causes. So if it's been there since birth, it's probably related to lymphedema, and the treatment may be simple, just compression or even observation if it's not causing any problems. When we start to talk about treatment, the things we look at are you getting infections in your feet? If you're getting infections in your feet, you need to have your edema treated. Are you getting physical discomfort? Is it changing in any way? So those kinds of edema problems, you may need to see a specialist, and we would recommend for this kind of problem a lymphedema clinic. Not everyone can get access to that, but a physical therapist can also sometimes help with edema problems related to lymphedema. If this is new edema, then it may be caused by a heart or blood vessel problem, in which case we recommend you getting your heart and circulation checked out before you do any treatment. Sometimes those are reversible. What recommendation do you have for an older TS woman with diabetes and 4 stents for blockages? So this would go into the atherosclerosis risk that we talked about. So most blockages are caused by cholesterol buildup or atherosclerosis. So in this kind of situation, you want to keep the cholesterol level in the blood as low as possible. So in that 50 to 70 range using medications. You want to have a diet that is low in saturated fat and low in salt. And you want to have regular exercise, which stimulates the blood flow and promotes good blood vessel health. All of those things would be necessary to prevent further blockages. Can you reverse atherosclerosis? Yes. So studies have shown that if you do those things by keeping your cholesterol really low and exercising, you can actually see the blockages shrink over time. That's why we think that these treatments are very effective, but they have to be carried out and sustained over months or years. You don't see that treatment effect overnight. My cardiologist recently had a cardiac CT. Is there anything I should be looking in the report to indicate the results have been appropriately adjusted for my height? So the answer is most radiologists will not do any adjustments for height in Turner syndrome. And that's actually for any condition whatsoever. They'll report the diameter, but it will be up to the cardiologist or the doctor who ordered the study to do the adjustment for height. So your question should really be directed to the other doctor, whoever it was that ordered the scan, and not looking at the scan report itself. What I would do is actually look at and do the measurement myself after looking at the scan, and then adjust it for height and report it in the patient's chart that way, because it can be very confusing if you just see the diameter and no adjustment. We don't usually adjust by height. As I mentioned, that's experimental, and we want to get information about how well that works for Turner syndrome, but we don't have that information yet. Right now, what we mainly do is adjust for your body's surface area, which is based on your weight and height together. How is ASI calculated? That is the ratio of the diameter of your aorta in centimeters to your body surface area in square meters. So that's your aortic size index. How do you find your Z-score? Z-scores are hard to calculate on your own. There's a formula or calculator that we use. There are some sites online where you can go, but it's very confusing. So I usually tell people to avoid trying to calculate their own Z-scores because it can freak you out if you use the wrong one. So if you're a kid, your pediatric doctor should use a standard Z calculator and tell you that at your report. You should be able to tell what your Z-score is. It's reported out. For adults, it's way more complicated. Some use the Z-scores, some use the ASI. As I mentioned, there's no standard, and we're working to change that. But for right now, it's really important to find a method that your doctor and you agree on, and you stick with it so you can tell whether it's changing or not. If you use different methods, you're going to be confused. So I recommend finding a method, agreeing with your doctor, and then making sure you know what that number is at each visit. We are out of time. Okay. Thanks, everyone.